Welcome to the What Does Science Say? Channel. Peace be upon you. Today we're diving into something nearly everyone experiences but often misunderstands. Headaches. It
Well,
seems simple, right? Just head pain.
yeah,
But what if it's way more complex than that? Our mission today is really to cut through some of that confusion, pull out the key insights, and leave you feeling genuinely well-informed about this, well, fascinating world of head pain.
absolutely. Because what seems like just one symptom, head pain, is actually, a huge spectrum. It ranges from things that are just annoying, frankly, to conditions that are potentially really serious. Understanding the differences, the nuances, is just vital to know what you're actually dealing with.
Okay, so let's get right into that. Not all headaches are the same. We see this key distinction made between primary and secondary headaches. Can you sort of break that down for us? What's the fundamental difference?
Yeah, it's the crucial first step, really. Think of it like this. With a primary headache, the headache is the condition. It's the main event.
Okay, it's the disorder itself.
Exactly. There isn't some other underlying illness causing it. But secondary headaches,
Hmm.
they're different. They are a symptom, a signpost maybe, pointing to something else happening in your body.
And that something else could be serious.
It could be, sometimes even life-threatening.
Yeah.
So making that distinction is, well, it's everything in the beginning.
Right, and that leads us straight into these red flags you hear about, these warning signs that kind of scream, hey, this might be more than just a standard headache. It's like a critical filter telling you when you absolutely need to seek medical help. And there's that acronym SNOOP or SNOP.
That's right, SNOP4. It's a really handy mnemonic for spotting features that suggest a secondary, potentially dangerous cause. Let's walk through it.
Okay.
So S is for systemic symptoms, think things like fever, unexplained weight loss, or if you already have a systemic condition like cancer, HIV, or maybe you're immunosuppressed. These suggest it's not just a headache.
Got it. Systemic. What's N?
N is for neurological symptoms. These are pretty clear indicators something might be going on with the brain itself. We're talking about new weakness on one side, maybe sensory loss, trouble speaking, sudden vision changes, or seizures.
Wow, okay. Any of those with a headache sounds like an immediate call to the doctor.
Absolutely. Then we have O for onset. Two key things here. One is a new type of headache, especially if you're quite young, say under 10 or older, over 50. But the really critical one here is a sudden, severe thunderclap headache. People often describe it as the worst headache of their life.
That sounds terrifying. What could that mean?
It could signal a subarachnoid hemorrhage, which is bleeding around the brain,
Mm.
a true medical emergency.
Okay, so SNO. What's the next O?
The second O stands for other associated conditions or features. This is a bit broader, like a persistent headache that's worse in the morning and comes with nausea. That might suggest increased pressure inside the skull, intracranial hypertension. Or a headache that changes dramatically when you change posture, like standing up or lying down. That could point towards a CSF leak, cerebrospinal fluid.
Right.
Also, if you have a history of headaches, but this one is progressing, getting worse, or his character has changed significantly, that's another warning.
Okay, that makes sense. So that's SNOOP. What about the four part? What are the P's?
Right, the SNOP4 adds 4 Ps for extra vigilance. First P is papilledema. This is swelling of the optic nerve at the back of the eye.
Something an eye doctor would see.
Exactly. During an eye exam, it's a direct sign of that increased intracranial pressure we mentioned.
Okay. Second P.
Second P is positional. We touched on this, but specifically a headache that's clearly worse when you're lying down and gets better when you sit or stand up. This can be linked to increased pressure, sometimes associated with things like brain tumors.
Right. And the third P.
Third P is precipitated by a Valsalva maneuver.
Valsalva. Remind us what that is again.
That's straining, like bearing down, or
Yeah.
even just, vigorous coughing or sneezing.
So just coughing could trigger a red flag headache. That's important to know.
It can, yes. If the headache consistently comes on or gets much worse with that kind of strain.
And the last P.
The final P refers back to progression or change in headache pattern, reinforcing that O point.
Yeah.
Any significant shift needs attention.
Okay, wow. That SNOP4 list is incredibly comprehensive. It really drives home the point. If you experience any of those signs, don't wait. Get it checked out professionally.
Precisely. Those are the situations where you don't self-diagnose or delay.
Okay. So if we've ruled out those serious secondary causes, the good news perhaps is that most headaches, what did you say, like 98% are primary.
That's right, the vast majority.
So the headache is the main issue. Now that we know when to be really concerned, let's dive into these primary types, the ones most people grapple with. Where should we start? Maybe the most complex one, migraine.
Migraine is definitely a big one. And you're right, it's far more than just a bad headache. It's a complex neurological disorder. It affects a staggering number of people, over 1 billion worldwide. And it's a leading cause of disability, particularly for people between, say, 10 and 50 years old.
1 billion. That's huge. And there's a gender difference too, right?
There is. Women are about 3 times more likely than men to experience migraines. It's a significant disparity.
Okay, let's really try to understand this. What's actually going on inside the brain when someone has a migraine attack? It sounds like a whole cascade of events.
It really is. Fundamentally, people with migraine seem to have a nervous system that's hypersensitive, kind of on high alert all the time. Genetics play a role, things affecting ion channels, neurotransmitter production, making neurons overreact to certain stimuli.
Okay, so the wiring is just a bit more sensitive.
You could put it that way.
Yeah.
And this often triggers something called cortical spreading depression.
Cortical spreading depression sounds dramatic.
It kind of is. Imagine like a slow wave of altered electrical activity sweeping across the surface of the brain.
Like a ripple.
Yeah, a slow ripple. And this wave then activates the trigeminal nerve system. That's the big nerve for facial sensation.
Okay.
Activation of the trigeminal system releases these inflammatory chemicals, these neuropeptides. The big one everyone talks about now is CGRP, calcitonin gene-related peptide. Substance P is another.
Right, CGRP. I've heard of that in relation to new treatments.
Exactly, because CGRP and Substance P cause blood vessels to dilate. They cause inflammation around the nerves and blood vessels in the brain coverings. And that leads to the pain, that throbbing pain characteristic of migraine. Serotonin levels also seem to play a part.
It's amazing how intricate it is. And a migraine isn't just the pain part, is it? It often unfolds in stages, sometimes starting way before the headache even hits.
That's a really key point. Not everyone gets all the phases, but recognizing them can be incredibly helpful. There are typically 4 potential phases. First is the prodrome. This can happen hours, even a day or 2 before the headache. Symptoms are subtle, sometimes weird.
Like what?
Things like excessive yawning, mood changes, irritability or euphoria fatigue, maybe sensitivity to light or sound starting, food cravings. Chocolate is a classic one people mention.
Huh. Chocolate cravings before the migraine.
Yep. Or increased thirst, neck stiffness, feeling cold. About 3/4 of migraine sufferers experience some kind of prodrome.
Fascinating. Okay, what's next?
Next, for about 1/4 of people, comes the aura. This is a reversible neurological symptom, usually comes before the headache or overlaps with the start of it.
Aura, like seeing flashing lights.
That's the most common type, yes. Visual auras, flickering lights, zigzag lines, sometimes blind spots called scintillating scotomas or shapes. But it can also be sensory numbness or tingling, often in an arm or leg, spreading slowly. Less commonly, people might have trouble speaking or even temporary muscle weakness.
And how long does an aura usually last?
Typically between 5 minutes and an hour. It should be fully reversible.
Okay. Prodrome, aura. Then comes the main event.
Then comes the headache phase. This is what most people think of as migraine. The pain is usually one-sided, unilateral about 70% of the time.
Just one side.
Often described as pulsating or throbbing, moderate to severe intensity. And it can last, well, anywhere from 4 hours up to 72 hours.
3 days. Wow.
Yeah. It's often made worse by routine physical activity. Just walking around can aggravate it. People usually want to rest in a dark, quiet room.
And there are other symptoms with the pain, right? Like nausea.
Oh, yes. Nausea is very common, sometimes vomiting too. Extreme sensitivity to light photophobia and sound phonophobia are hallmarks. You might also get a runny nose, watery eyes, even something called allodynia.
Allodynia. What's that?
That's when things that shouldn't be painful, like a light touch to the skin or hair brushing against the scalp, actually feel painful.
Gosh. Okay, so after the headache finally subsides, is it just over?
Not always. There's often a post-drome phase. People call it the migraine hangover.
Ah, okay. Makes sense.
They can feel totally wiped out, exhausted, irritable, maybe have trouble concentrating, feel a bit dizzy. This can last for another day or so after the pain is gone.
It's like a whole multi-day event for some people.
It really can be.
So, given this complex process, what actually sets off these attacks? What are the triggers we should know about? Are they the same for everyone?
That's the tricky part. Triggers are highly individual. What triggers one person might be totally fine for another.
Right.
But common ones definitely emerge. Stress and anxiety are big ones. Sleep changes too much, too little, or just irregular sleep. Very common. For women, hormonal fluctuations are key changes in estrogen around periods, pregnancy, menopause, or even from hormonal medications.
Okay. Environmental things, too.
Yep. Bright or flashing lights, loud noises, strong smells, perfume, chemicals, weather changes like barometric pressure shifts. And then there are dietary triggers for some people. Things like aged cheese, red wine, caffeine, sometimes too much, sometimes withdrawal chocolate, MSG, processed meats with nitrites, even just skipping meals or getting dehydrated.
It sounds like keeping a diary could be really useful then.
Incredibly useful. Identifying your personal triggers is probably one of the most powerful self-management tools you have. Gives you some control back.
Absolutely. So, with all these variations, how does a doctor actually diagnose a migraine? Is there a specific test or is it more about the story?
It's very much about the story, the clinical picture. Diagnosis is based mainly on your detailed history, describing your headaches, the pattern, the symptoms, and matching those to specific criteria from the International Classification of Headache Disorders, the ICHD.
So, lots of questions from the doctor.
Lots of questions about the type of pain, where it is, how long it lasts, how often, how intense, what comes with it, what makes it better or worse, family history. That headache diary we mentioned, it's gold for diagnosis.
And scans, like CT or MRI, are they usually needed?
Usually not for typical migraine patterns. They're generally reserved for situations where the symptoms are unusual, or if those SNOP4 red flags pop up like a first severe headache over 50, or if there are neurological signs between attacks.
Okay, that clarifies things. So once someone has a migraine diagnosis, what's the approach to managing it? It sounds like it needs a few angles.
Definitely multi-pronged.
Yeah.
You need strategies for dealing with an attack when it happens, and strategies for trying to prevent them or at least make them less frequent and severe.
Right. Let's start with prevention and lifestyle.
Lifestyle modifications are foundational. Avoiding your known triggers is number one. Maintaining a really regular sleep schedule, 7-8 hours, consistent bedtime and wake time. Staying hydrated. Regular exercise, though sometimes strenuous exercise can be a trigger during an attack. Regular moderate activity is generally helpful. And stress management is huge. Things like yoga, meditation, biofeedback, cognitive behavioral therapy, CBT, can all make a difference.
Okay. And what about when an attack actually hits? What are the options then? Acute treatments.
Right. Acute or abortive treatments, you take them at the first sign of an attack to stop it, or at least lessen its severity and duration. For mild to moderate migraine, sometimes over-the-counter options work. NSAIDs like ibuprofen or naproxen or acetaminophen, often formulations with caffeine, are a bit more effective.
Okay. But for more severe attacks?
For moderate to severe migraines, you usually need prescription meds. Triptans have been a mainstay for years. Sumatriptan is the classic example. They work on serotonin receptors. There are also older drugs called ergots, like dihydroergotamine. And more recently, we have the CGRP antagonist. These can be taken orally during an attack, like ubrogepant or rimegepant, or sometimes injected. They specifically target that CGRP peptide.
And anti-nausea meds, too, I guess.
Oh, absolutely. Often prescribed alongside the pain meds. Sometimes people need IV fluids if they're vomiting a lot and get dehydrated.
Okay, so that's dealing with the attack itself. What about trying to have fewer attacks overall? The preventive side.
Preventive or prophylactic treatments are taken regularly every day to reduce the frequency, severity, and duration of attacks. These are considered if attacks are frequent, debilitating, or if acute meds aren't working well or are overused. There are several classes of drugs used. Beta blockers, like propranolol, calcium channel blockers, like verapamil, some antidepressants, particularly amitriptyline, certain anti-epilepsy drugs, like topiramate or valproate. For a chronic migraine defined as 15 or more headache days per month, with at least 8 having migraine features, Botox injections are an option.
Botox for migraines.
Yes, specific injection patterns around the head and neck, typically done every 3 months. And now we also have the injectable CGRP monoclonal antibodies like erinumab, fremanezumab, galcanezumab, specifically designed for migraine prevention.
Wow, lots of options there. Okay, let's shift gears. Migraines are complex, but what about the headache type most people say they get? Tension headaches.
Right, tension-type headaches. These are definitely the most common. Vast majority of people experience them at some point.
How do they typically feel? Different from a migraine.
Generally, yes. The classic description is like a tight band or pressure around the head, often on both sides bilateral. The pain is usually dull, aching, mild to moderate in intensity. Importantly, it's not usually throbbing or pulsating like a migraine.
Okay, more of a steady pressure.
Exactly. And they can last anywhere from 30 minutes up to a whole week, though most are maybe 4 or 6 hours. Unlike migraine, they don't typically cause significant nausea or vomiting, and they're usually not made worse by routine physical activity. You might get some mild sensitivity to light or sound, but not the extreme levels seen in migraine.
And what usually brings these on? Is it really just tension?
Stress and muscle tension in the neck and scalp are definitely major players, hence the name. But other things contribute too. Poor posture, eye strain, fatigue, skipping meals, dehydration, anxiety, even dental problems like teeth grinding.
So how do you usually treat a tension headache? Is it simpler than migraine treatment?
Generally, yes. Over-the-counter pain relievers are often effective. Paracetamol, ibuprofen, naproxen. Sometimes caffeine can help too. But addressing the triggers is key. Managing stress, ensuring you get enough sleep, staying hydrated, taking breaks from screen time, maybe physical therapy or massage for neck tension. For people with chronic tension headaches, sometimes low-dose antidepressants like amitriptyline are prescribed, or occasionally muscle relaxants, though those are used cautiously.
Okay, that makes sense. Common, generally manageable. Now, let's talk about the other end of the spectrum. Cluster headaches. You hear these described as suicidal headaches, which is just horrifying. What makes them so uniquely awful?
They are truly excruciating. Cluster headaches are less common than migraine or tension headaches, thankfully, but they are considered one of the most painful conditions known to medicine.
More painful than?
People have compared the pain favorably to things like kidney stones or childbirth. The pain is severe, intense, often described as sharp, boring, stabbing, or burning. It's almost always strictly unilateral, one side only, typically centered in or around one eye or the temple.
Always one side.
Almost always the same side for an individual during a cluster period. And the attacks themselves are relatively short compared to migraines lasting maybe 30 minutes to 3 hours.
But they come in clusters, right? That's the name.
Exactly. That's the defining feature. They occur in bouts or clusters that can last for weeks or months. During a cluster period, a person might have anywhere from 1 attack every other day up to 8 attacks in a single day.
8 attacks a day. That sounds unbearable.
It is. And they often occur at strikingly regular times, sometimes waking people from sleep, hence the nickname alarm clock headaches.
And the symptoms with the pain are different too, aren't they? You mentioned something about Horner syndrome.
Yes, the associated symptoms are very characteristic and reflect involvement of the trigeminal nerve and autonomic nervous system on the affected side. You often see a partial Horner syndrome, that's a drooping eyelid, mitosis, and a constricted pupil, meiosis, on the side of the pain. Also very common are eye redness, tearing, nasal congestion or a runny nose, facial sweating, all on that same side.
And behaviorally, people react differently than with migraine.
Very differently. Unlike migraine sufferers who want to lie still in the dark, people having a cluster attack are typically restless, agitated. They might pace, rock back and forth. They just can't get comfortable.
Who tends to get these?
They're more common in men, typically starting in their 20s or 30s, and there seems to be a strong link with smoking. Alcohol can also be a potent drug during a cluster period, though not necessarily between periods.
Given that intensity, treatment must need to be fast and effective.
Absolutely. Acute treatment needs to work quickly. The two mainstays are high-flow oxygen therapy, breathing 100% oxygen through a non-rebreather mask at about 10-12 liters per minute, can abort an attack in many people within 15-20 minutes. Yes, it's remarkably effective for many. The other first-line option is injectable sumatriptan, the triptan drug. It works very fast when injected under the skin. Nasal spray versions of triptans can also be used.
And preventing these clusters?
Prevention is crucial. Verapamil, a calcium channel blocker, is often the first-line preventive medication, though it needs careful monitoring. Lithium is another option. Sometimes anti-epilepsy drugs like topiramate are used. Often a short course of oral steroids like prednisone is used as a bridging therapy when starting a preventive med to try and break the cycle quickly while the main preventive drug takes time to kick in.
Right. Okay, so migraine, tension, cluster. Those are the big three primary headaches. Now, let's tackle a really common misconception. So many people say, oh, I get terrible sinus headaches. But is it always the sinuses?
Ah, yes, the sinus headache. This is probably one of the biggest areas of confusion for patients and sometimes even doctors. Now, true sinusitis inflammation or infection in the sinus cavities can cause facial pain and headache. It's usually described as a dull pressure or ache, often worse when bending forward, and it comes with other clear sinus symptoms: thick nasal discharge, congestion, maybe fever, reduced sense of smell.
Okay, so actual sinusitis does cause head pain.
It does. But here's the thing. Studies have shown that the vast majority estimates range up to 80 or even 90% of people who think they have recurrent sinus headaches, especially if they don't have those clear signs of infection, are actually experiencing migraines.
80 to 90%. That's huge. Why the confusion?
It comes back to that trigeminal nerve we talked about with migraines.
Right.
It not only carries pain signals from the face and head coverings, but it also innervates the mucous membranes in the nose and sinuses. So during a migraine, activation of the trigeminal nerve can cause symptoms like nasal congestion, runny nose, or facial pressure, even without any actual sinus infection. People feel the pain and pressure in the sinus areas and assume it must be their sinuses.
So the migraine itself is causing the sinus-like symptoms.
Exactly. So if you're getting frequent sinus headaches without clear signs of infection like fever or discolored discharge, especially if the pain is severe, throbbing, or associated with light sound sensitivity or nausea, it's much more likely to be migraine presenting with sinus-like features.
That's a massive takeaway. If you have chronic sinus headaches, maybe talk to your doctor about the possibility of migraine.
Definitely worth exploring.
And just briefly, another factor we touched on, hormones, particularly for women, that connection is quite strong, isn't it?
Very strong. Fluctuations in estrogen levels are a well-established trigger for migraines in many women. This is why you see patterns related to the menstrual cycle. Menstrual migraine is a specific subtype. Headaches can also change during pregnancy, often improving, and then again around perimenopause and menopause as hormone levels shift erratically and then decline. Use of hormonal contraception or hormone replacement therapy can also influence headache patterns.
It really highlights how individual these experiences are, tied into our own unique biology.
Precisely.
Wow, we have covered so much ground. From spotting those critical red flags for secondary headaches, to really unpacking the complexities of migraine phases and triggers, distinguishing the common tension headache, understanding the sheer agony of cluster headaches, and even debunking that sinus headache myth.
It's been quite a journey through the landscape of head pain, and I think it really underscores that headaches aren't just a minor nuisance for many people. They're complex neurological events. Hopefully, understanding the different types, what might be triggering them, and the science behind it all empowers you, the listener, to have better conversations with your doctor, manage your own headaches more effectively, or perhaps understand a loved one's experience better, because knowledge really is power here.
Absolutely. So thinking about all this, what's one thing that stands out to you about how our understanding has evolved? Or maybe one thing you'll consider differently about headaches now? Something for all of us to reflect on. Thank you for being with us until the end of this video. Please be sure to subscribe to the What Does Science Say channel and give us energy with your likes and comments. Share your comments with us and send the video to your loved ones so that others can also use it.